Thank you very much for the kind introduction, and I'd like to thank the organizers, especially Professor Juliana Chan, for the kind invitation to this wonderful meeting. So this is my financial information to disclose. Today I'm going to talk about the importance of the comprehensive management by presenting the data from our DOIT-3 data. Due to the advances in the treatment, in the incidence of diabetic complications has been declining year by year. This is a survey. This is the survey of the causes of death among people with diabetes conducted by every 10 years by the Japan Diabetes Society. This is from myocardial infarction, stroke, and renal disease shown in red. Which accounted for more than 40% of all the deaths in the 1970s, declined into 40.5% in the 10 years between 2001 and 2010. Data from the 2011 to 2020 survey is currently being compiled, but what I'm showing you the result of our hospital survey. As you can see, people with diabetes are no different from the people without diabetes in terms of age of death and the cause of death. And currently many guidelines, not only in Japan and also in other countries, set the target of A1C at less than 7%, which is not considered sufficient to completely suppress the complications. It is also considered important to intensive care in the blood pressure and lipid. The STENO-2 study was the first to demonstrate the effectiveness of such comprehensive management for diabetic complications. After 7.5 years of the intensive therapy, the macrovascular complications were reduced by 53% by the intensive therapy compared to the standard care. For diabetic nephropathy, the intensive therapy also suppressed by 61%. However, compared to the targets of the current guidelines, the control of the blood glucose, blood pressure, and the lipids in the conventional therapy group was very inadequate, and blood glucose control, even in the intensive therapy group, was not at all on target. Therefore, it was deemed necessary to examine whether the blood glucose, blood pressure, and lipid targets set in the current guidelines were sufficient to control diabetic complications, and whether more stringent targets were needed. So in 2005, the Japan government launched the 3 strategic studies aimed at curbing diabetes and its complications. DOIT-1 is a study to prevent the onset of diabetes by intensive lifestyle intervention. DOIT-2 is a study to curb the dropouts from diabetes treatment, and DOIT-3 is our study to test whether the integrated interventions can control vascular complications. DOIT-3 was originally named Japan Diabetes Outcome Trial 3, but was changed to the Japan Diabetes Optimal Integrated Treatment Study for 3 major risk factors of the cardiovascular diseases. So DOIT-3 enrolled 2,540 patients, much larger than STENO-2 trial, with a type 2 diabetes and hypertension or dyslipidemia. The primary endpoint was a composite of death, myocardial infarction, stroke, or revascularization. And the main secondary endpoint was a composite of death, myocardial infarction, stroke. And the other secondary endpoints included diabetic nephropathy and diabetic retinopathy. In the conventional therapy group, as you can see, the goal was to achieve the current guideline targets for blood glucose, blood pressure, and lipids. In the intensive therapy group, the goals were A1C below 6.2%, blood pressure 120 over 70 millimeter mercury, and LDL cholesterol level should be less than 80 milligram per deciliter. And the intervention lasted a mean of 8.5 years. This is the patient baseline data. The mean age was 59 years. A1C was about 8%. eGFR was 82 milliliter per minute. And 23% of the patient showed the albuminuria. There was a small imbalance in the smoking with significantly more smokers in the intensive therapy group. So the black bars shows the baseline data, and the blue lines shows the targets values for the conventional therapy group, and the red lines show the targets values for the intense therapy group. Then A1C in the conventional therapy group was 7.2%, which did not reach the target, but blood pressure and lipids achieved the targets. And the intensive therapy group, blood pressure and lipids were somewhat well on target, but A1C was only 6.8%. This is partly due to the fact that during the study, the result of the ACCORD trial and other studies revealed that the severe hypoglycemia was a risk for the complications and death, forcing the researchers to ensure that the treatment avoid the hypoglycemia. Then, as a result, when they adjusted for the smoking rate, the primary endpoint was 24% lower with the intensive therapy group, particularly stroke, which was a 58% lower. Renal events were significantly reduced by 32%. And compared to the previous studies, the frequency of severe hypoglycemia is about 1/100th. So, and renal events in this study included the development of microalbuminuria, progression to the macroalbuminuria, doubling of serum creatinine, and introduction of the permanent dialysis renal transplantation, which is significantly reduced by 32% with the intensive therapy, as I mentioned. And of the renal events, development of microalbuminuria accounted for the majority and was significantly suppressed by the intensive therapy. But the doubling of serum creatinine, which is close to the hard endpoint, was also suppressed by 50%. Then within the study period, 5 cases of the dialysis occurred in the conventional therapy group, but 0 in the intensive therapy group. An analysis of what factors contributed to the suppression of the renal events with the factors after 1 year of the initiation of intervention shows that for every 1% increase in A1C, there was a 21% increase in the renal events. Blood pressure and other factors were not significantly associated. In terms of the impact of the intensive therapy on the eGFR decline, there was no overall impact on eGFR slope. On the other hand, in those who had an eGFR below 60 at baseline, the intensive therapy significantly affected the slope of the eGFR. Again, when the data from 1 year after the initiation of the intervention were analyzed in terms of the effect on this eGFR decline, systolic blood pressure was the only factor influencing the decline. So also, as shown, 23% of the DOIT-3 participants had albuminuria at baseline. but 42% of the conventional therapy group and 54% of the intensive therapy group showed remission respectively. Very interestingly, similar to the result of STENO2 study, there was a 59% reduction in the outcomes of the myocardial infarction, stroke, and deaths in those who went to remission compared to those who did not go to remission. I don't know whether this is due to the cardio-renal linkage or whether the treatment to improve the albuminuria is effective in reducing the cardiovascular disease. In any case, regular measurement of urinary albumin and the treatment to decrease the albumin levels may help reduce not only diabetic kidney disease but also cardiovascular disease. However, our analysis of the national database shows that only 20% of the patients with diabetes in Japan have their urinary albumin measurement once a year, unfortunately. So the study compared A1C trends of the patient who had cardiovascular or renal events with those of the patient who did not have the cardiovascular or renal events in the 3 years before the events. In particular, A1C of the patient who developed diabetic kidney disease stayed above 7%, although the protocol asked the researchers to enhance the treatment of A1C didn't reach the target, suggesting the kind of clinical inertia, unfortunately. So the STENO2 study analyzed which factors of the comprehensive management had an effect on the reduction of the cardiovascular events and to what extent, and reported that most of the effect was derived from the lipid control. However, as I mentioned, glycemic and blood pressure control in STENO2 study was not totally inadequate. So the DOIT-3 study also looked at the impact of A1C, systolic blood pressure, LDL cholesterol, and HDL cholesterol on each event. As you can see, a 1% increase in A1C increases the risk of any events by about 40%. And interestingly, a 1 milligram increase in HDL cholesterol decreases the risk of any event 1 to 2%. For renal event, 1 milligram increase in the blood pressure is associated with the 1.4% increase in the risk. The stratified analysis of A1C by subgrouping into below 6.5%, between 6.5% and 7.5%, 7.5% and 8.5%, and a upper 8.5%. Also shows the 35% increased risk of the renal events, even in the region that includes the current guideline targets of 7%. So stratified analysis was also performed for other factors. For systolic blood pressure, there was also performed other for systolic blood pressure. There was already a 29% increased risk in the area containing 130, the current guideline target, compared to the less than 120. So there was no specific association between LDL cholesterol level and kidney disease. Keeping HDL cholesterol above 60 showed a significantly reduced risk compared to the below than the level. So the DOIT-3 provided the intensified education program on lifestyle modifications, including the instruction, the exercise, which was probably effective in rising the HDL cholesterol level. So taken together, this shows the current guideline targets. But to prevent diabetic kidney disease, A1C probably less than 6.5%, systolic pressure less than 120, and HDL cholesterol greater than 60 can be recommended. And last year, the Japan Diabetes Society published the algorithm for pharmacotherapy for type 2 diabetes, which differs from the ADA and ESD guidelines. In that first set individual A1C targets, then determines which group should be used, taking into the account considerations such as obesity, and from that excludes the drugs that cannot be used due to the complications. If the patient has a chronic kidney disease, steps are taken such as considering the administration of SGLT2 inhibitors, for which there is the evidence. In addition, the Japan Diabetes Society is aiming for personalized medicine, including real-world evidence from the large-scale registry in the fourth 5-year strategic plan against diabetes, which is starting at 2020. Then Japan Diabetes Society and our own institution have been collaborating since 2015 by a J-DREAMS diabetes registry that sends not only laboratory and prescription data, but also electronic medical record information such as blood pressure, body weight, medical history, family history, and when complications occurred directly to an integrated database, which currently has more than 90,000 cases registered. Using this registry, we plan to examine which treatment methods are useful in controlling complications and how cost-effective they are, and reflect the result in the guideline. For example, the database shows that the people with more advanced diabetic kidney disease have larger, longer disease history, while the patient with type 2 diabetes show worsening renal function faster than those with type 1 diabetes. That's quite reasonable. However, those with the end-stage kidney disease are significantly younger than those with earlier stage of the disease in both type 1 and type 2 diabetes. So this means that the people who develop diabetes at a younger age are more likely to develop end-stage kidney disease, and therefore more rigorous treatment should be required for those people. So we are also developing a real-time medical guidance function for non-specialists that will be integrated into EMR in the future by machine learning J-DOIT-3 data and J-DREAMS data, which can recommend the most effective drugs for preventing the complications and economically superior performance when the patient background is entered in EMR. Our partner, Hitachi company, already developed an add-on app for the EMR at the University of Utah that displays a degree of the decline A1C and cost after 6 months initiation of the drug treatment. So that's we hope we will launch more advanced version of the app in the near future. So before wrapping up, I'd like to thank all the collaborators in our J-DOIT-3 study. Thank you very much for kind attention.
Thank